Options.
There are many disorders that can affect the heart's ability to function normally. There are also a variety of procedures and medications used to treat heart disease and keep it from getting worse. If you've been told you need heart surgery, you probably have a lot of questions and some concerns as well.
Pause. Play.
Our goal is to care for and support you and your family and ease your mind about what you will experience. This presentation covers important things you need to know and what will happen before surgery, on the day of surgery, during surgery, after surgery in the hospital, and discharge. We also give you information about how the heart works, and there is a section devoted to frequently asked questions. Please review this information with family and friends and write down any questions you may have. And as always, please talk to your doctor if you have any questions or concerns. The heart is a muscle about the size of your fist. It lies behind and to the left of your breastbone or sternum. The purpose of the heart is to pump blood through blood vessels, arteries, and veins to all parts of your body. The inside of the heart is divided into 4 chambers. The top 2 chambers are called the atria and are collection chambers for blood. The bottom 2 chambers are called the ventricles and receive the blood from the atria and pump it to the lungs and the body. The chambers are separated by valves, which control the direction of blood flow. There are 4 valves: tricuspid, pulmonic, mitral, and aortic. Circulation begins at the right side of the heart, where blood from the body comes to the right atrium. This blood passes to the right ventricle, where it is pumped to the lungs to receive oxygen. Once it receives oxygen, it flows to the left atrium and then to the left ventricle, where it is pumped to the aorta and the rest of the body. On the right side of the heart, the tricuspid valve separates the right atrium and the right ventricle, allowing blood to enter the ventricle but not flow backwards to the atrium. Blood flows through the pulmonic valve to go to the lungs. On the left side of the heart, the mitral valve separates the left atrium and the left ventricle. Blood flows from the left ventricle to the aorta through the aortic valve and to the rest of the body. Arteries carry blood with oxygen and other nutrients throughout the body. Veins take blood back to the heart, which pumps it to the lungs to be oxygenated. The heart arteries, coronary arteries, provide oxygen and nutrients to the heart muscle. The right coronary artery supplies blood to the bottom and the back of the heart. The left coronary artery splits into 2 vessels. One branch supplies blood to the front of the heart. The other branch delivers blood to the left side of the heart. An electric system transmits signals throughout the heart to control its pumping. The electrical signal starts in the sinoatrial or SA node, which is located in the upper portion of the right atrium and is known as the natural pacemaker of the heart. The electrical signal passes down to the lower chambers of the heart via the atrioventricular or AV node, which controls the signals so the atria contract before the ventricles. In the ventricles, pathways carry the signal throughout the muscle so that they contract at the same time to pump blood to the lungs and through the body. The process will begin with questions about your health history, medicines, and allergies. Some tests will be done before surgery. Blood work. Speak with your surgeon or cardiologist about donating your own blood before surgery. Urine test. Electrocardiogram or EKG. Chest X-ray. Other tests may also be done. Cardiac catheterization or angiogram to assess blockages or narrowing in the arteries and functioning of the heart valves and muscle function. Echocardiogram. Carotid ultrasound to assess blood flow to the brain through the carotid arteries. Ultrasound of leg or arms to evaluate blood vessels. Pulmonary function tests to determine the condition of the lungs. Before your surgery, we ask that you follow these instructions. Check with your doctor about continuing any medications you are on. You may need to stop taking certain medications for 5 to 7 days before surgery, such as drugs that thin your blood, including aspirin and aspirin products, Plavix, and Coumadin, and certain vitamins and supplements, including vitamin E, omega-3, fish oils, ginkgo biloba, St. John's wort, ginseng, and garlic. You will need to stop drinking alcohol, including liquor, beer, and wine, 2 days before surgery. If you smoke, you need to quit at least 3 weeks before surgery. Smoking increases your risk for pneumonia and other lung complications after surgery. Do not eat or drink anything past midnight the evening before surgery. On the morning of your surgery, you should take only the medications your doctor has approved with a small amount of water. Use antiseptic soap provided to you the night before and the day of surgery. If you receive nasal ointment to decrease the chance of infection, use it before surgery according to your healthcare provider's instructions. Discharge planning begins before you are admitted. Plan to have someone with you for the first few days at home. If you live alone, you may want to prepare meals that can be placed in the freezer, clean your home, and have your laundry done. A social worker can help to arrange home care services or rehabilitation after surgery if you qualify. You will be admitted as either a same-day surgery patient or an inpatient. Same-day patients need to arrive at the admitting area at their designated time, several hours before the scheduled operation time. We ask that a family member or friend accompany you. Inpatients and transfer patients are admitted a day or more before surgery. Before entering the operating room, you will meet with an anesthesiologist. Intravenous lines for medicines may be started, and an arterial line may be inserted into a vessel to monitor blood pressure and draw blood samples. After you are completely asleep in the operating room, a tube will be put into your windpipe to allow a machine called a respirator to take over your breathing. A large intravenous line will be placed in your neck, and a catheter will be placed in your bladder. Your family can wait for you in a waiting room during the surgery, or they can leave a phone number where they can be reached. The surgeon will contact them when the operation is over to let them know about your condition. Coronary artery bypass surgery, sometimes referred to as CABG, is used to treat coronary artery disease. When the arteries on the surface of a person's heart become blocked from receiving blood flow, it may be necessary to use segments of the person's own veins or arteries to bypass or go around the blockages. The vein or artery is attached to an alternative source of blood, most commonly the aorta, to supply blood and oxygen to the area of the heart muscle not receiving blood due to the blockage. These blockages result from the slow buildup of plaque, which is made up of fat, cholesterol, calcium, and other substances. As plaque builds on the inside walls of the arteries, the inside of the artery becomes narrower, a condition termed atherosclerosis. Risk factors associated with coronary artery disease include age, diabetes, family history, high blood pressure, high cholesterol, lack of exercise, obesity, smoking, stress. Blood flow to the heart muscle is seriously reduced when one or more of the patient's coronary arteries is narrowed to less than 30% of its original size. At rest, there may be enough blood flow to meet normal needs even if 70 to 90% of the artery is blocked. But with exercise or stress, blood flow may be insufficient to provide the heart with enough oxygen. In time, restricted blood flow and oxygen delivery to the heart muscle can lead to heart attacks, angina, decreased exercise ability, and weakening of the heart muscle. Restoring blood flow to the heart muscle may require surgery. Your doctors will determine whether or not you may benefit from bypass surgery based on your specific case. Some of the common reasons for undergoing the CABG procedure include the left main coronary artery is severely blocked. There are multiple severe blockages. Valve replacement or other open heart surgical procedure is also needed. All CABG procedures involve rerouting or bypassing blood around blockages in the coronary arteries to restore blood flow to the heart muscle, which can improve your ability to exercise and your quality of life. A bypass is constructed from an artery or vein from the chest, arm, or leg. More than one artery or vein may be used if multiple bypasses are created. Different approaches to CABG include performing the procedure through a single incision in the chest, called an open or conventional procedure. Or it can be done through smaller incisions, as a minimally invasive procedure. And it may be done on pump, which means a heart-lung machine is used during surgery, or off pump, which means a heart-lung machine is not used. This program contains more information about all these alternatives. In conventional CABG, the most common way of doing the procedure, the surgeon makes a vertical incision, called a sternotomy, down the center of the patient's chest. The breastbone is divided and retracted, and the pericardium, a thin layer of tissue surrounding the heart, is opened to expose it so that the vessel grafts can be attached. Vessels used for the grafts are harvested. These vessels include the internal mammary arteries from the inside of your chest, or the radial artery from the arm, or the greater saphenous vein from the leg. One end of the blood vessel being used for a bypass is sewn to a source of blood supply, most commonly the aorta, and the other end is sewn to the coronary artery, below the level of the blockage. The vessel creates a new route for the blood around a blocked artery and restores blood flow to the heart muscle. This procedure is repeated for each blockage being bypassed. When all the bypass grafts have been put in place, the surgeon rejoins the tissue surrounding the heart, the sternum, and closes the chest. Among the choice of vessels used for a bypass, the internal mammary artery from the chest wall is used when possible because the bypass generally lasts for the patient's lifetime. This approach also offers advantages when the left anterior descending artery is clogged. The left internal mammary artery can be quickly exposed, separated from the chest wall, and grafted to the coronary artery beyond the narrowing or blockage. Other arteries and veins used to bypass multiple blockages include the greater saphenous vein from the leg, and, less frequently, the radial artery from the arm is used. The vessels used to create bypasses may be removed from the leg or arm using 3 different harvesting techniques. The first, called an open technique, utilizes a single long incision down the arm or leg. The second, called a bridging technique, uses multiple short incisions on the arm or leg. The third option is called EVH, or endoscopic vessel harvesting, where a single small incision is made on the arm or the leg, and a device is used to find and remove the vessel. EVH utilizes a single 1-inch incision that is made below the knee or wrist. EVH is a minimally invasive procedure. The benefits of EVH include reduced scarring, less wound complications, and faster recovery time. Once the vessel is obtained, it is then used to bypass the blocked artery. Depending on your surgeon, hospital, and other factors, CABG may be performed on pump or off pump. In an on-pump procedure, the heart is stopped during surgery, and you are put on a cardiopulmonary bypass machine, also called a heart-lung machine, which takes over the function of the heart and lungs. Blood flows from your heart to the machine, oxygen is added, and the blood is pumped back to the body. A clamp is put on the aorta to restrict blood to the area of the graft and allow the graft vessels to be attached. When the surgery is finished, the heart-lung machine support is gradually reduced. The clamp is removed, your heart takes over the pumping of blood, and your lungs return to their normal function. Most CABG procedures today are done using the on-pump approach. In an off-pump procedure, a heart-lung machine is not used, and the heart remains beating during surgery. Stabilization and positioning devices are used to hold the heart steady while the surgery is performed. Off-pump surgery also differs from on-pump surgery because the aorta is typically not clamped. There is increasing evidence that not clamping the aorta reduces the risk of particles of plaque in the aorta breaking off, which can potentially lead to a stroke or other complications. A heart-lung machine is always available so the surgeon can put you on it if necessary. Off-pump surgery was originally developed to reduce the risks of surgery in high-risk patients, such as those with diabetes, renal problems, women, or the elderly. Off-pump surgery is being used in a variety of patients to reduce blood transfusions and potential problems such as neurological deficit, and to speed recovery. A minimally invasive method may be used as an alternative to the sternotomy during CABG. Using much smaller incisions to access the heart, a minimally invasive technique can help to decrease trauma, minimize scarring, and speed up return to normal activities. Depending on the patient, a surgical robot may be used to assist with the minimally invasive procedure. Based on the surgeon's actions, the robot moves the instruments, which are inserted in the surgical incision along with a 3D camera. Most minimally invasive and robotic procedures are performed off-pump because the chest is closed during the procedure. While many CABG procedures are performed using a conventional approach, an increasing number of patients are candidates for less invasive techniques. However, off-pump surgery and minimally invasive surgery can be more technically challenging than on-pump surgery and may not be appropriate for everyone. Talk to your surgeon about which treatment options are right for you. The CABG procedure itself usually takes 3 to 5 hours, but total time in the operating room is usually 4 to 6 hours because of the time required for preparation for surgery, giving anesthesia, and preparing for transfer to the intensive care unit. You will wake up in the intensive care unit, where you'll stay for approximately 12 to 48 hours. Most patients are discharged from the hospital after 3 to 6 days, depending on factors such as age, physical condition before surgery, motivation, condition of the heart muscle, and complications during and after surgery. Specifics about care after bypass surgery depend on the type of procedure, pre-existing conditions, and how quickly you recover. Part of the recovery process is learning about and modifying risk factors associated with coronary artery disease, such as smoking and high cholesterol. It is important for you to be involved in your recovery and in the control of your risk factors. After surgery, you will be taken to the intensive care unit, where you'll stay for the next 12 to 48 hours. You'll have a breathing tube until you are awake and strong enough to breathe on your own, usually 6 to 24 hours after surgery. Most patients do not remember this time. While on the mechanical ventilator, you will be sedated and given pain medications through the intravenous tube. Your arms may be restrained until the breathing tube is removed so that you do not accidentally pull on it. A nurse is always near you during this time. You will have 2 to 3 chest tubes to drain blood and fluids, intravenous lines, temporary pacemaker wires, a catheter in your neck, and a catheter in your bladder. Your blood pressure and heart rhythm will be monitored continuously. As you wake up, you will hear many noises and be aware of tubes and wires attached to you. Most are removed within a day. Family can visit you in the ICU, and they may be surprised to see that you are still connected to a variety of medical equipment. It is important for them to know that these tubes and wires are used routinely for open-heart surgery. Even with all this equipment, you should still be able to move around in bed with the assistance of a nurse. When you are ready, you will be transferred to the telemetry unit. This unit is specifically for recovering heart surgery patients, and the nurses have been specially trained. The usual stay on the telemetry unit is 3 to 6 days. As you continue recovery in the cardiac unit, you will become increasingly independent while remaining in a safe environment. At this point, there is less need for extensive monitoring equipment, but your heart is still monitored 24 hours a day. Breathing exercises and walking to prevent such complications as pneumonia and blood clots are now very important. You will be expected to become independent through your breathing exercises and walks. It is easy to become fatigued, so limit visitors if you need to. Your sternum, or breastbone, was closed with stainless steel wires, and the skin was sutured. It needs at least 6 weeks to heal completely. During this time, you should restrict activities, including limiting lifting to 7 to 10 pounds at most. If you had minimally invasive surgery, your incision was a small one between the ribs or along the upper portion of the breastbone. Although you may have a faster ultimate recovery, incisions between the ribs may be more painful than traditional incisions for the first few days. You should avoid lifting and pulling with your arms during this time. You should also use your incentive spirometer to practice deep breathing and cough to remove the secretions out of your lungs. Using your pillow or bear while you cough helps decrease pain and stress on the breastbone. Many people retain too much fluid in their bodies right after surgery. You may be given diuretics for several weeks after surgery to help you lose this excess fluid. About a third of patients experience palpitations, or episodes of an irregular and sometimes fast heartbeat, for up to 3 months after heart surgery. These will be monitored by your local cardiologist. To prepare you for discharge, you may attend cardiac classes or receive individual instruction covering incision care, physical activity, breathing exercises, sleep and appetite problems, pain control, and emotional recovery. At this time, you may ask to speak to a dietitian about your diet and a social worker regarding home care visits. You will be ready for discharge to home when your blood pressure and heart rhythm are stable and you can get out of bed with little or no assistance. You may still be experiencing such side effects of surgery as loss of appetite and constipation, swelling in the area where a blood vessel was removed, muscle pain or tightness in your shoulders and upper back, and fatigue, mood swings, depression, or insomnia. These side effects are normal and are usually gone by 6 weeks after surgery, but your full recovery may take several months or more. It is normal to feel anxious during this time. Discuss any concerns you may have with your cardiologist. After 2 to 4 weeks, your local doctor may prescribe outpatient cardiac rehabilitation to increase your physical activity. You will need to talk with your surgeon about returning to work. The time may vary depending on the individual patient and occupation. If you've had minimally invasive surgery, you may feel ready to return to work and normal activities within a few weeks after discharge. If you feel like returning to work and normal activities before your 4 to 6 week follow-up visit, call your surgeon's office and check directly with him or a physician assistant if the office utilizes one. Hopefully, this educational information has provided for you a more complete understanding of how cardiac surgery can help you. These procedures are done hundreds of thousands of times per year and have helped millions of people to live safer, more comfortable lives. Our goal is to provide you with the information you need to understand your problem, the goals of surgery, and what to expect before and after the procedure. As always, please discuss any questions or concerns with us.
can't operate.